Hi, everyone. My name is Dr. April Jasper, and I'm the Chief Optometric Editor of Optometric Management Magazine. It is exciting to be here with you today, but mostly because I get to spend some time with Dr. Nate Lighthizer. So Nate and I have been friends for a long time, but what I love most about you, Nate, is that you are so available and very uh, cordial about sharing your information and the knowledge that you've gained in the setting that you're in. So I'll tell you a little bit about Nate. He is the Associate Dean and Professor at NSU Oklahoma College of Optometry. But I really want you, Nate, to tell everybody a little bit more about yourself. So go ahead and do that for us.
Thanks, Dr. Jasper. First off, thank you for inviting me to this podcast. Really looking forward to it. We're going to have a lot of fun over the next 15 minutes or so. Nate Lighthizer, I was born and raised in North Dakota. I did my optometry school at Pacific University out in the West Coast. After I finished school, I did my residency at the Oklahoma College of Optometry here in Tahlequah, Oklahoma, back in 2009, 2010. That's how I got down to Oklahoma. And I was fortunate that they had a couple of faculty positions open when I finished my residency, and they hired my wife and myself. My wife's an OD as well. And I serve in various roles at the College of Optometry. I'm the chief of our specialty care clinics, which is where we do our laser procedures, our injections, lesion removals, specialty glaucoma care, things like that. Associate Dean and the director of our continuing education program. So just love being here and love doing things like this with you, Dr. Jasper.
I love it. You stay busy, it sounds like. And I know you have two children just like me.
Yep. 9-year-old Addie, she'll be 10 in March, and 6-year-old Camden, he'll be 7 in April. So almost 10 and almost 7. My wife, Jenna, I won't give her age because that would get me in the doghouse there, but she is on faculty, and just feel very fortunate to have the wife and kids that I do. Very supportive.
That's awesome. So for all of you who are listening today, I just want to remind you, we will take questions. So go ahead and type in your name and your practice and any questions that you have, and we'll leave time for that at the very end. But we're excited today because what Nate and I get to talk about is Reichert's Ocular Response Analyzer and corneal hysteresis. And I think, Nate, if you agree that there is still a lot of information that people don't know about corneal hysteresis. And so we want to spend a little bit of time on that today. So let's start with, what is corneal hysteresis?
Yeah, corneal hysteresis is something that, even you go back 10, 15 years ago, I don't know if I remember, maybe I just forgot or slept through that day at school, but I don't remember hearing a whole lot on corneal hysteresis, 15 years ago. Really over the course of the last 6, 7, 8, 10 years, we're starting to learn that this corneal hysteresis measurement is important, especially in our glaucoma patients. I describe it to patients as the shock absorbing properties to the eye. How well does your eye absorb those shocks that it gets, whether it's the high IOP? Yeah. I was talking to a student this morning. We had a 4th-year optometry student. We were in laser clinic this morning, and I had a glaucoma patient that I've been seeing. And the 4th-year student, I said, let's bring him back and let's get some corneal hysteresis measurements. And she wasn't overly familiar with what the ORA was. And I said, well, Reichert makes the Ocular Response Analyzer. She knew what corneal hysteresis was. And as I described it to her, I said, think of your car. If your car had terrible shocks, you'd be bouncing down the road and you're damaging the car and maybe yourself as you have poor shocks on the car. Same thing with the eye. If the eye has poor shock absorbing properties, the eye is more likely to be damaged and more susceptible to elevated intraocular pressure, things like that. So I think it is the shock absorbing properties of the eye. And you want to have a higher hysteresis. The higher the number, the better, as we'll talk about here in just a little bit.
So that's a great way to explain it, not only to us, but to patients. I love that. A great tip. And I have the Ocular Response Analyzer in my practice, so that's helpful for me as well. So let's now talk about how you incorporate corneal hysteresis into your glaucoma decision making. So walk me through, you talked a little bit about the number. Yep. And where it might need to be or should be, but then what do you do from there?
Yeah, so, it's a piece of the puzzle. We all know that we have no perfect tool in glaucoma. We have all these pieces of the pie, all these pieces of the puzzle, and it's been an amazing piece of our puzzle when we're managing glaucoma. And it's a number that gives me an idea of what is their risk of progression. How worried should I be about this glaucoma patient? Should I follow them up more closely instead of maybe seeing them back in a year? Maybe it's 6 months instead of 6 months. Maybe it's 3 months. If I have a patient that has a corneal hysteresis number of 10 and a half, 11, which is in the normal ranges. I always tell our patients and our students and residents, above 10 is typically, I'm feeling good about that. As we get below 10 into the 9s and especially into the 8s or 7s, the risk of progression goes up significantly. There has been a lot of literature out there that shows that for every point that corneal hysteresis falls, you've got a much greater chance of visual field progression over the years. So it's a risk factor for progression in glaucoma. So we look at it heavily. And the beauty is you can implement it very easily, as I think we'll talk about in just a second, because it truly is an objective reading.
So I hear this. So we now have a number. We know how it should influence our thinking. But then how does it help you manage your glaucoma patients? Tell me how you then move forward and teach students to move forward with utilizing that information to change their behavior.
Yeah. So I saw a patient this morning. It was a 61-year-old male that has severe glaucoma in his right eye based on visual field criteria, his mild in the left eye. And his corneal hysteresis was 7.9 in the right eye, and it was 10.1 in the left eye. And it matched everything perfectly. The IOP was 20 today in the right and 12 in the left. Again, mild over here, severe in the right eye. And we told the student and resident and the patient that you can see in the hysteresis the worrisome nature that we have of progression in this particular patient. And we went from instead of maybe adding a second drop, we are referring that patient for a combination cataract surgery as well as glaucoma surgery. I'm going to be a little bit more aggressive in that younger patient with an elevated IOP and a low corneal hysteresis because the rate of progression, the risk is certainly higher.
Wow. So, we all know that Goldman tonometry has limitations. We've talked a little bit about that even on this broadcast. Does corneal compensated IOP, and you'll tell us a little bit more about that, provided by this ocular response analyzer, does it provide you with greater confidence than Goldman measurements?
I don't know if I'd go greater confidence, at least equal confidence with Goldman. Goldman has traditionally been the standard. The beauty about Reichert's ORA, the ocular response analyzers, you get more than just the corneal hysteresis. Yeah, it gives you that number, and that's one of the main ones I look at, but it gives you what's called an IOP-CC, which is a corneal compensated IOP. It's less dependent on all the variables of the cornea that can affect our IOP. And we're all very familiar how corneal thickness, among other properties, can affect our IOP reading. So to have that IOP-CC reading, it gives me here's what the IOP is, largely independent of what the corneal properties are, which is nice to have. It also gives you an IOP-G, which is an IOP Goldman equivalent. So I have that Goldman. This is what your Goldman reading should be. And by the way, in that patient this morning, it matched identically. The IOP-G is what the student got for their Goldman. So they passed for the day. They're doing Goldman well. The IOP-CC was a little bit higher than the IOP Goldman, the IOP-G, and then the corneal hysteresis. So to have different readings and different variables is nice. But the nicest thing is you can have a technician, you can have, in our case, a student or a resident. They get this reading and it's objective. It's not about lining up the Myers like Goldman, which is truly subjective. You would do that a little bit differently than I would. So there's some subjectivity to Goldman. This is objective and it takes very little time. You just have their forehead up against the forehead rest. It auto aligns and puff, 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 and it gives you those readings. So it's been very nice to have those multiple readings.
So then I think the next thing I would want to know is how do you determine who you're going to get this measurement on?
Yeah, it's largely in our glaucoma patients, not entirely, but largely in our glaucoma patients, our glaucoma suspects, the patients where I just need some more information. We've all been on the fence in glaucoma where you look at it and you go, is that glaucoma? Is it not glaucoma? Are they just a suspect? Or you have a glaucoma patient. Is it progressing? Is it stable? Is it not progressing? To have that hysteresis measurement and an objective measure to have the IOP as well is nice. To be able to go this way or that way, it's another piece of data, and it's dictated our treatment a lot of times.
So does that measurement change over time?
It certainly can. And I think it can give you an indication of how well is your treatment doing. Yes, maybe their IOP is good, but yet that reading is still 7.5 or 7.9 or 8.3. We've still got a low corneal hysteresis. So our risk of progression is still higher than I'd like. And that may change my treatment. I'm going to add that second drop. I'm going to consider an SLT. In this patient this morning, it was cataract surgery and a MIGS recommendation. So it's going to determine what am I going to do in each individual patient, or at least help that.
Wow, good. So what about people that are listening are probably going, okay, so I don't really even know what this machine looks like. So tell us a little bit about how easy it is to incorporate into practice the ocular response analyzer.
So again, the quote from my fourth-year student this morning, when she wasn't overly familiar, she knew what corneal hysteresis was, but she had never seen this device. And her exact comment was, wow, that looks just like our standard, NCT machine. It's very small, sits on the table. And she goes, but it obviously does a lot more than that. And that's absolutely true. And that was her exact quote a couple hours ago. So it's easy to implement. Doesn't take a whole lot of space. It sits, right next to your other instruments. And literally they put their head up against the forehead rest and you align their right eye and you hit the button and it auto centers and puff, 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 and it does its thing. So it's very easy to do. What I like about it is I can walk in the room as the clinician, as the doctor, and going, I've already got IOP Goldman, IOP-G, IOP-CC, and corneal hysteresis. I've got 3 readings at my disposal that I can quickly look at and help me to make decisions. So the efficiency is a big benefit as well.
So what are some of the other benefits? Anything else that we left out that you think is important? I know that the things that really, to me, have stood out, and I mean, I've had one, I think I'm on my second device just because I liked the newer one was streamlined, smaller footprint, so I had to have another.
Yep.
But what are some of the other benefits that you have found that we haven't talked about so far?
Yeah, again, the efficiency has been very, very nice. I think that's one of the main things, the efficiency, being objective. You have a lot of different doctors in your practice. We have doctors and students, and to be able to have that same reading every time, to be objective. I think that's very nice to have, the efficiency, the objectiveness. And again, just another reading makes it very, very nice when you're looking at your glaucoma patients.
Perfect. So I know one of the questions, Nate, that I hear often, and so I'll just ask you that now. Do you still need to do Goldman tonometry as well if you have this device?
Yeah, that's a really good question. Do you still need to do Goldman? I would say Goldman is still a nice measurement to have. You should never have a glaucoma patient that you never do Goldman on.
Right.
Do you need to do Goldman on every visit? I think there would be visits where I would be comfortable going, I've got this reading with the IOP-G, the IOP-CC, and the corneal hysteresis. I wouldn't do that on every visit because I, as the doctor, would still want to see the eye and measure the pressure myself. But I could see visits where this could, they're there for a quick IOP check, and we did this, I've reviewed, and we're good at that point. I could see visits where it'd be okay with that, but I wouldn't do it every visit.
Okay. And then the other question people often ask is, you sort of answered it. You keep all 3 of those measurements. You write them down somewhere. You enter them into your EHR, correct?
Correct. We really wrote down 4 readings for each eye today, the 3 that we've talked about already. And then there's a waveform score as well that basically gives you how reliable is the reading. That goes from 0 to 10. Anything above 6 is good. 4 to 5 is acceptable, and less than 3 is poor. It's basically the equivalent. Most of us have OCT devices. When we do OCT scans, you want a 7 out of 10, an 8 out of 10, a 9 out of 10, not a 3 out of 10. Similar thing here. So 4 numbers I record in the chart: the IOP Goldman, the IOP-CC, corneal hysteresis, and what's the waveform score? What was the quality of the measurement?
And the other question I get often is, how does refractive surgery affect this measurement, or does it at all?
So refractive surgery is going to affect this much, much less than obviously corneal thickness. We know central corneal thickness certainly can affect our IOP, and with refractive surgery, that can affect that. With this, the literature has shown minimal effectiveness on the corneal hysteresis, which makes it very nice.
Wow, I love that. I mean, honestly, that's one of my favorite things too, because I think that helps a lot when you're looking at decision making, to put all of those pieces together, like you said. And I think you said it brilliantly at the very beginning. The ocular response analyzer and corneal hysteresis has just been another piece to the puzzle of glaucoma, which is still not completely solved, is it?
Yep, it is not. We have no perfect diagnostic test. We have no perfect treatment. We add up all the variables, we make a decision, and you follow those patients closely. As we know, glaucoma is a progressive optic neuropathy looking for changes over time, and this is one of those things that helps us.
This has been amazing, Nate. I knew it would be. Thank you for sharing with everybody, and to all of the audience, thank you for watching. Nate, if you wouldn't mind, I would love for you to jump on and join us again to talk more about not just ocular response analyzer and corneal hysteresis, but that puzzle of glaucoma. But thank you for being here today with us.
Thanks for having me. It's my pleasure, and would love to do it again sometime.